Welcome to Pharmacology! Hello! For this section, we'll go through the other drugs which are also proven to be very useful in angina treatment. So the first one that we'll go through is called CCB, which is the calcium channel blockers. Bear in mind that the drugs for this section, I'll only be going through them very briefly because it's also being covered in other classes such as hypertension and so on. Right, so as what you have learned previously, CCB is divided into two main groups, which is the dihydropyridine ones. They're divided based on the chemical structure. So the dihydropyridine ones are the dipins, right? And also the non-dihydropyridine ones, which include the verapamil and diltiazem. For the use of angina, you actually need something which acts more directly on the heart itself. So therefore, verapamil and diltiazem is more useful in the context of angina. Right, so the difference between these three groups in a way is due to the selectivity of the different calcium channel blockers, right? So obviously the most cardioselective ones will be on the verapamil. Okay, so therefore it can cause a direct effect of depression of the automaticity on the SA node, depression of the conduction of on the AV node, and also on the contractility and slight reduction on the vasodilation, therefore causing an overall reduction in the myocardial oxygen demand of the heart. Right, so based on the site of action, a little bit more graphical detail. So again, it works on the SA node, on the AV node, on the cardiomyocytes, right, coronary arteries, a little bit on the peripheral veins as well. Right, so yep, make sure you know clearly which CCB has a greater effect on which site. Okay, another component which is called the beta blocker. Right, so again, beta blocker, as you already know, it can actually reduces the automaticity at the SA node. So it reduces the heart rate, reduces the blood pressure, reduces the contractility, therefore reduces the workload of the heart. Right, especially useful to reduce the myocardial oxygen requirement, especially during exercise as well. Right, so if you look through the BNF, there's actually different types of beta blocker. Right, so for the use of angina, there's actually almost all types of the beta blockers can be used. For example, like bisoprolol. Right, here I actually introduced three newer drugs. They're relatively new, basically available in the last 5 years, approved to be used in the last 5 years, in a way, plus minus. Right, so they're Nicorandil, Ivabradine, and Ranolazine. They're important pharmacologically as well because this drug actually has a new pharmacological target. So maybe they might not be the best one for the current one, but who knows, there might be other newer drugs which will act on the same target in the near future. Right, so let's go through Nicorandil. So what happens is that it actually acts on the potassium channels, which is rare. It's one of its class actually. So basically it acts on the potassium channel, right? So it causes it to open, right? Then to cause dilation of the small vessels, decrease afterload. It also has some effect like a nitrate-like action to cause dilation of the large vessels, as seen here at the venodilation. Right, so it's good to be used as a prophylaxis and a treatment for stable angina. However, it causes some weird side effect, which is like mouth ulceration, as well as ulcerations at other parts, so which is nasty. However, the good news is that in most cases, the ulceration resolves automatically after the drug has been stopped, right? So that's why it's probably not the most famous drug in the market. Right, so there's Ivabradine. So this one is again a bradycardic drug. So basically, they're trying to develop drugs which some acts as a similar way. Oh, sorry about the thunder. Acts a similar way like beta blockers, but it's available for other people who have contraindication for beta blockers to be able to use these other drugs. Right, so it's a bradycardic drug. Again, causes bradycardia, which is slower heart rate reduction. Through a selective IF sodium channel blocker. Right, so basically reduces the depolarization slope, so therefore reduces the heart rate. So yeah, so it goes up a little bit slower, right? It acts on the SA node, so it's useful for angina. It's also useful for chronic heart failure as well, again to reduce the workload of the heart. So the good part is that it actually doesn't lowers the blood pressure, so it's a good alternative also for asthmatic patients who, as I say, they can't really use beta blocker that much. Right, so yep, reduction in the sodium channel. So the effect of it, you have to refer back to the physiology of how basically the heart works. So the sodium channel, so it's part of to cause the depolarization of the membrane. So when you reduce that, so the depolarization becomes slightly slower, so therefore causes an overall of a reduction in the heart rate. Okay, but it's not much used now for angina because there's this trial on it Signify which actually says that they don't see an improvement in the mortality rate of these patients. So yeah, but still, it's still an option. Okay, another one here is called Ranolazine. So this one, the pharmacological action of it is a little bit more complicated in a way. So it again acts on the sodium channels, but this one acts on the late sodium channels. So they're trying to say that over here there's in the cardiac ischemia conditions and so on, there's cause an overload, and because this under these conditions the sodium channel will be open. So for Ranolazine, so imagine this sodium when it enters, so it can cause a change in the effect of this sodium calcium exchanger. So let's look at here. So yeah, this is how the sodium calcium exchanger works. So 3 sodium in exchange with 1 calcium, right? So it can switch both sides. So imagine if a lot of sodium is inside here, so it can actually switch the membrane to work this way, right? So there's more sodium chance to move out because there's too much inside, so which in the end causes a pull in of calcium ions into the cells. This would then cause a calcium overload, and if you remember clearly on one of the slides from the previous one, which says that calcium is involved in the contraction, so therefore there's more contraction, higher contractility. So it's not so good. So therefore Ranolazine is actually an inhibitor over here, right, which stops the whole process. Right, so Ranolazine inhibits that. So therefore it reduces the late sodium current, right? So therefore there's less calcium entry, so there's less cardiac contractility. So that's another diagram here. So Ranolazine. So in terms of the mechanism, we actually have to mention that it's actually a late sodium current. Okay, so yep, that's how it works. Right, so based on all the angina drugs, as you've seen all the way through, so for different people there's actually a different preferred drugs, right, and also drugs to avoid. So do have a look at it here. So it's similar like all the other contraindications as well, right? So yep, there you go. And also there's also effects of the combined therapy, so it's quite common to use combination as well, because for example some are desired effects. So for example, if you look at the nitrates here, so as we've seen in the nitrate one, it actually at higher doses it can actually cause a reflex tachycardia. Oops, sorry, thunder. Reflex tachycardia. So therefore, if you use nitrates together with a beta blocker or verapamil, actually cause a good effect in a way, right? So it causes a decrease in the heart rate. So therefore, reducing the reflex tachycardia. Sure. So yep. So the others are, so it's a good thing, right? So basically you can combine to counteract their disadvantages. So the last slide here is just to show you actually in the overall management of myocardial ischemia or angina and the different types of myocardial infarction. So there's different drugs that comes into place, right? Overall, to cause preventing the cells to be dead, the myocardial cells to be dead. So if they are dead, so you can imagine it can causes a lot of subsequent problematic events in a way, because they cannot conduct the electricity, the current, the ions, the electrical signal across properly, and so on and so forth, to cause further problems like arrhythmia and also probably later like heart failure, because the heart just doesn't have enough healthy cells to survive and to work properly. Right, so there's also thrombolytic agents over here, right? So there's ARB and ACE inhibitor because there's pain, so opiates are also into place, and also the beta blockers here as well. Okay, hopefully it helps. Okay, see you next round.